Thank you, sir. Thank you to the BOS Scientific Committee for including me in this session. I am going to speak on complex retinal detachment. So what is REGARDI? It is basically a separation of neurosensory retina from retinal pigment epithelium due to secondary to any breaks, vitreoretinal traction and liquefaction of the vitreous leading to migration of fluid behind the retina. Simple retinal detachments are very easy to manage, and a proper surgery at a time generally restores complete vision to majority of the patients. But many a time due to neglected or delayed diagnosis, patient may develop complex detachment, and generally complex detachment happens in long-standing untreated detachment, detachment secondary to large breaks, multiple breaks, or due to bad trauma, vitreous hemorrhage, choroidal detachment. If there is a large break and PVD, then PVR settles very early and it leads to complex detachment. If a patient redetaches after vitrectomy, that case also progresses very fast, leading to complex detachment and PVR. In modern day, vitrectomy system has improved the outcome even in cases of complex detachment. These are some classifications of PVR and all. This is not important for this session. We would directly proceed to management techniques, and this is a surgery for a complex detachment, simpler among the complex. There is a large superior break leading to a total rhegmatogenous RD with significant PVR. So we have to clear the vitreous properly, and after clearing the vitreous, we have to remove those membranes, and these membranes are generally immature membranes. So generally these membranes are little bit difficult to remove because it breaks very easily. Whenever we grasp with the forceps, generally it breaks and doesn't come in toto. So we have to put PFCL, stabilize the retina, stain the membranes with dye, and then we can remove all the PVR membrane, or rather do a wide ILM peel, which includes all the membrane as well as PVR changes. And then we can laser all around and settle the retina, putting a silicone oil inside, and can close the case. So another complex detachment we can see, this is 270-degree giant retinal tear, and the retina is torn and completely folded upon the optic nerve. We cannot see the optic nerve in this case, and then initially we clear the vitreous, do the vitrectomy to relieve the tractions, and then we can unfold that folded GRT and reattach those giant tears. Here we are using our vitrectomy cutter as the forceps. We have just switched off the cutting and just use little bit traction and then unfold the retina. This saves time actually. The multifunctionality of these vitrectors advanced machines has saved time a lot, and we are now finishing this vitrectomy and in a very less time. Putting PFCL, settling the retina, then unfolding, rubbing, lifting the edges by this soft tip silicone tip cannulas, and then do laser all around, and then we have to do in these cases direct silicone oil PFCL exchange. If we are going for a fluid air exchange and then we are putting PFCL, putting silicone oil, then sometime there might be slippage of that GRT due to retained fluid seepage. So it is better to do direct PFCL silicone oil exchange, or if we are going to do that FAE, then we have to dry the retina completely and then inject silicone oil. So again, this is a case of horseshoe tear, large horseshoe tear at the macula. So there was a large tear over the macula, and it was an old detachment, and that leads to temporal detachment actually. And in this case, vitrectomy was done, vitreous was stained with triamcinolone acetonide, it was removed, and then we did ILM peeling. But since the edges of the hole was very ragged and it was large, it was not possible to close the hole with just ILM peeling or inverted flap. So we decided to do a retinal autograft technique. So we harvested a part of the retina from the supernasal portion of the attached retina. And actually harvesting a graft from attached retina is a little bit difficult, but in this case we did laser all around to a piece of the retina, and then we cut it with the diathermy, and then we took out that part of the graft and placed it on the macula, and that fantastically got attached there, and even after SOR, the retina was fantastically attached, and we got away with a good attached retina without lasering that macula. Otherwise, we had to do laser over the macula, and that would actually destroy the functional part of the retina, and that is not a very good technique to settle these cases. So these cases also have saved a lot of eyes in which initially we used to during our training time there were very less reported cases of retinal autograft, so our teachers used to do laser around the macula. If it is a bad tear, large tear, to settle the retina they used to do laser. But now these techniques, or sometime amniotic membrane graft, also leads to fantastic settlement in such cases of large macular tears. This is all about my presentation, and we can see that even with a good effort, such complex cases can also be taken care. And this patient was one-eyed patient and just perception of light vision. And after a long operating time, we could settle some reasonable part of the retina, leading to useful vision for that patient. Thank you so much for all your attention. Thank you, sir.
Yes. This autograft is a very interesting thing. But what is the ultimate visual outcome with these autografts?
That patients are surprisingly improved to 6/18. Generally, we do not expect more than 660, 636 vision, but after silicone oil removal and cataract surgery, that patient improved to 6/18 vision. That was very surprising. Even we do not expect such kind of vision in such cases, but sometimes we do get good vision.
Thank you, sir, for the talk.
The tear was at the edge of the fovea, that is why.